Top Med Talk.
Nick Majerison here. This piece is taken from the Society of Cardiovascular Anesthesiologists annual meeting. We're going to be looking forward to their new meeting, which is happening on April the 18th through to the 21st this year. Make sure you pop along and you can have a chat to the Top Med Talk team when we're there. Want more details? The place to go. SCA HQ. That's scahq.org. I hope you enjoy the podcast.
Well, welcome to Top Med Talk. We are here in Chicago at the Society of Cardiovascular Anesthesiologists 41st annual meeting. I'm Desiree Chappell, host and managing editor of Top Med Talk, and I'm joined by Saul Aronson, my co-host, and I have to say it, Saul, you're a past president of the SCA.
She keeps rubbing that in.
You have a ribbon on your badge. Take it off then.
I am very proud of this ribbon.
You should be
I just feel
proud.
very old wearing it.
No. Yeah. So you've been a recent past president of the SCA. We'll say that.
Thank you.
Well, we've had the opportunity to sit down with some of the program committee, the people involved with the SCA. But one of the great things that we do with Top Med Talk is we're able to talk to attendees, the delegates here, and find out what's really happening on the ground. And Saul, would you like to introduce our guest?
Himani Bhatt is a past fellow. I don't want to make you seem old now, but you haven't. And current friend. And also the director of cardiovascular anesthesia at Mount Sinai, Ichan School of Medicine. Very proud to say that. What a pleasure to have you.
Yeah, thank you for having
Himani.
me. Yeah. I always appreciate, any invitation from Saul Aronson's always going to be fun. So I usually say yes, and then I ask what it is.
What am I going to be doing now? I know. It's okay. I've learned the wisdom of Saul. It's all good. Well, Himani, thank you so much for sitting down with us. Just what's going on, happening on the ground? What are some of the things that are really important to you right now going on in your own personal practice?
Having taken over as chief of cardiac, I've seen that a lot of the practice overall has really grown into different therapies right now. It's not just a matter of the open heart, the traditional, conventional open heart surgery that everybody knows about. A lot of cardiac surgeons and then therefore anesthesiologists are evolving their practice into catheter-based therapy, minimally invasive, robotic surgeries, and we do a lot of those different types of procedures at both of the sites that I staff as a cardiac anesthesiologist. I'm seeing a growing trend towards not only adapting a lot of these therapies, but the anesthesiologist has to learn how to manage these patients perioperatively, and they have to change their practice, and they also have to grow and adapt to a lot of these therapies that are being initiated by a lot of hospital systems today.
So Himani, when you say the cardiac anesthesiologist needs to grow and adapt to so we're talking about, would you say this is in the zone of structural cardiology, or are we talking about things that are even beyond that?
So beyond that. So the one aspect of that is structural heart disease. Right. And so the average cardiac anesthesiologist has to, one of the skills that I think defines cardiac anesthesia from general anesthesia is the knowledge of TEE, of transesophageal echocardiogram. And a lot of these catheter-based therapies are echo-guided. Echocardiography is one of the multimodal imaging modalities that are being used now. And a lot of the clinical team relies on the cardiac anesthesiologist to help really direct a lot of these therapies. So that's one thing. The second thing is robotic surgery, minimally invasive robotic surgery, which is a different topic, but still is the trend towards our aging population and providing them with other options. So when I talk about robotic surgery or minimally invasive surgery, that comes down to, the concept that not only do you want patients to have additional options, but also you want to quote unquote fast track them. You want to be able to provide them with great perioperative care and make sure that they're home and capable and they're back to quote-unquote life again in a few days.
Yeah.
And so that goal has led to a lot of these additional types of unconventional therapies that are being offered now. So let's take, for example, at one of the institutions that I provide care for, we do a lot of robotic procedures, robotic coronary artery bypass procedures. And these patients, they want to go home in 3 or 4 days. That's why they're looking for these alternative methods. So one of the things that we do is we give them a dose of some kind of non-opiate therapy the day of surgery, prior to surgery. I've incorporated a lot of regional anesthetic techniques in a lot of these procedures also to provide them with pain relief or an adjunct pain relief. And then, of course, this has evolved into a real pain management technique that continues to provide them with the appropriate pain management for about anywhere between 24 to 48 hours.
Share with us what those blocks or techniques are.
Sure.
Be more specific.
I love absolutely.
Yeah.
So one of the things I do is when my patients come the day off, so most of these patients are same-day admissions. So when they come to my holding area, after assessing them and making sure that they're good candidates for this multimodal therapy, Celebrex or some sort of, or I even use acetaminophen, as a matter of fact. So I give them an oral dose of all of these medications, some sort of non-opiate medication. Then when they go inside, I either do pectoral nerve 1, pectoral nerve 2, anterior serratus, or I do an erector spinae block on them, depending on what the procedure is and what the distribution is going to be based on where the port placements will be. These are plain blocks. They're truncal/plain blocks, and they have gained a lot of popularity right now in not only multimodal therapy, but just overall anesthetic techniques.
And I would add, safe with the anticipatory anticoagulation management.
Absolutely. So that's a big thing with cardiac surgical patients that are cardiac cripples. Many of them have pulmonary comorbidities, and in addition to the fact that, well, you're going to have to worry about anticoagulation, these blocks are all plain blocks, and they are all safe to do. Now, of course, there has to be techniques, and you have to take care in anything that you do to a patient. Yeah. But again, you can do these blocks on patients that are anticoagulated, and that's a big plus.
And ultrasound guided.
And absolutely, and ultrasound guided. So there's this collaboration, which is unique now that I'm seeing a lot more of. Because maybe 10 years ago or 5 years ago, the regional anesthesia was doing their own thing, and cardiac was doing their own thing, and thoracic. It's not like that anymore. You have to come together, and you have to formulate these plans to better take care of patients.
We were just talking to a resident yesterday that she wants to do 2 fellowships. Possibility.
One in pain and one in cardiac.
One in pain and one in cardiac.
Which is wonderful. And speak to us more about the perioperative sort of domain, which is to say, you communicate, you discuss, you message these sort of plans with your patients preoperatively. How do you do that? What are the things that we should know to look for? What are the pitfalls? What are the burdens? And what are the rewards? Help us understand how you're implementing this in your practice. And then I'm going to ask you to speak to the transition to care afterwards as well.
Well, a lot of this is in the beginning. It's in the works right now. And there's been a lot of push towards enhanced recovery models that many people have heard of. So we are in the process of developing one, and so it provides me with a good forum to look at these multimodal techniques and whatnot. So most of the time the patients are introduced to these therapies prior to the surgery, of course. One of the anesthesiology team will reach out to them either by phone or in person during their pre-op testing time and mention to them that these are the techniques that we're going to be providing. We're going to give you this dose, this medication the day of. We're going to take you in. We're going to sit you up, lie you down, do these blocks. So the whole process of what is going to be provided for them, just so they're aware of what's going on. Also, I particularly, and my team particularly, make sure that they understand that this is part of this multimodal technique. So it's not one technique that's going to provide you with no pain. That's not really what it's about. Yeah. There's no such thing as no pain. But these are all adjuncts to provide you with as much pain management or other modalities to provide you with much pain management as possible. Yeah. So this is introduced to the patient not only prior to, but the day of the procedure. Intraoperatively, this is discussed with the whole surgical team. Now, once you get this established, it's the same thing again. And so you don't have to redo that all the time. But prior to actually going and really initiating a lot of this, I sat down with all the surgical team and I said, hey, listen, this is what we're going to be doing. Let's see how it works. I think it's going to provide this with your patients and our patients with A, B, and C advantages. And, there's a lot of data that is slowly coming out. It's very new. Yeah. So it's when they say, well, give me some outcomes data, the reality is that I don't have hardcore outcomes data. These are just things that they're established blocks. I think according to the nerve distribution, they're going to work. And let's see how this works out. So a lot of this comes down to collaboration with your surgical colleagues and in to initiate anything, you have to make sure you talk to them and provide them with the foundation of what is it that you're going to be doing and how it may benefit the patients.
So, I'm just so enamored and proud of everything you are doing and have done.
Good.
It really is a pleasure to see someone like you who is taking the foundations of a wonderful fellowship and training and just pushing the envelope and passing this forward. We look forward to you capturing the outcomes of what you do and sharing this with us. And I just want to say thank you for sharing your experiences with us. It really is important to see how we integrate what we have learned and what we currently know how to do.
Absolutely.
So from all of us, we say thank you.
Yeah.
Well, thank you for having me. I appreciate it.
Thank you so much for listening to Top Med Talk. And you can be sure to pick this up on topmedtalk.com, or if you subscribe to iTunes, Apple Podcasts, you can catch it there. Himani, thank you so much.
No worries.
Cheers.
Thank you so much.
Top Med Talk.
It's Desiree Chappell here. Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.